Thanks for coming to this session. I know it's the last session of the day, and you're probably tired from all the other sessions and being in the exhibit hall and all that. So I hope that I know you will enjoy this if you're especially in the healthcare space, and even if you're not. How many of you here are in the healthcare space? Okay. Oh, wow. Great. Great. Fantastic. So maybe we'll get some ideas today of how you could use the platform to move things in your organization, because I think data is a powerful storyteller, And in healthcare, we need a lot of change, and many times people need to be convinced that, some problem actually exists. So we use Domo for those types of purposes, to reveal to people where the problem is, and then have them acknowledge that, and then change, okay? So, and we think certainly that platforms are very powerful. In fact, we have this equation for digital transformation that says that great teams plus great partners plus great platforms is what results in good digital transformation. So welcome and thank you for coming in here. We're gonna get real in a bit, okay? And talk about real-time insights to optimize patient care and how we do that at Jefferson Health. But before I get into the content, I wanted to spend a few minutes providing some context. Thomas Jefferson University and Jefferson Health, how many of you know about the institution? None, wow, yeah, that's very rare. But Thomas Jefferson University and Thomas Jefferson University Hospitals, as it was called before, is the third medical school in the country. So it's been around since 1824, very old institution, very prestigious institution also. How many of you have heard of gross anatomy as a subject in medicine, right? Well, Samuel Gross was a Jefferson physician, and he started gross anatomy in an auditorium-style classroom where he operated, and he and a few other docs operated and taught on cadavers. And this was in the 1800s, so it was kind of taboo at that time. In fact, we have a painting called the Gross Clinic that recently sold for about $64 million. It's an age-old institution, but also an innovator. Having been embedded in the Philadelphia area, as you can see, Philadelphia has a huge concentration of medical schools, colleges, hospitals, and is among the 6th most innovative cities in the U.S. Lots of patents coming out of Philadelphia, and especially in the healthcare, education kind of space. And also its proximity to a lot of other places like New York and D.C., hence we can pull some good people to do work with us. We also created the first school of population health, and that's a Jefferson product. But our fastest growth has been in the last 4.5 years. So I joined Jefferson about 4.5 years ago. So did our president and CEO, who brought the university and the hospital system together. And they were separate entities before. And since then, we had about 3 hospitals, 1 university. In the last 4 years, we've gone to about 18 hospitals, gone from a revenue of about $1.8 billion to about $6.5 billion with the recent Einstein acquisition. And, lots of employees. We have about 38,000 employees. And, with such kind of growth comes the need to collect a lot of data, synthesize a lot of data, and then reveal it to other people within the organization, new acquisitions that you've created, reveal issues and problems very quickly, and that's one of the ways we use Domo. So this gives you some context, but for us, the biggest and most important numbers is our patients, and that's why I italicize that. We do about 3.2 million outpatient visits a year. We have about 520,000 ED visits, and one of the examples I'll show you actually hits those 520,000 lives each year, and has created great impact in our ERs. And in the hospitals, we have about 150,000 admissions, and we have about 3,500 inpatient beds in our hospital. So a medium-sized hospital system. There are larger hospital systems, of course, like Kaiser and Providence that you might know of. And the way that we organize our team, so this is to give you a little context about my group and the group that I lead. So I'm the Chief Digital Officer at Thomas Jefferson University and Jefferson Health System across the enterprise, and also the EVP for Tech Innovation and Consumer Experience. My past background, I've worked in different types of digital revolutions or evolutions. I've worked in the education space before, then in healthcare, a business model that kind of has worked for me in the past is one where you set up an organization, a lean startup kind of organization inside a large organization to help disrupt it a little bit and bring it to the point where you want it to be. Kind of like what Clayton Christensen says if you read his books. It's very hard to do that, but we did it in education about 8 to 10 years ago, and that's why you can now watch Clayton Christensen speak in a course at Harvard Business School while you're in India somewhere, right? And although Harvard Business School initially resisted this change, we were able to use data and create a business model behind that, and then show them, and show organizations like HBS the value of providing education everywhere. And we're trying to do the same now with healthcare, which is a lot more resistant, a lot more conservative to this type of change. But it's at this point, it's you either do it or you perish, right? So this is our company inside a company, right? So what we did was we said, okay, well, to bring about a lot of change at the confluence of technology, innovation, and consumer experience, which is mostly how a lot of other industries and companies inside of industries have brought about a lot of change. If you read about Amazon, they focus religiously on the consumer and what they might need even before they realize what they might need, right? And then deliver it. So you can come up with the best of ideas, but if you cannot execute, then you have a problem. And they had the advantage of being first to market to try and do that, right? But now they've grown. How do they keep that momentum going and not rest on their laurels? Well, a lot of it is through showing people what's really happening, collecting a lot of data from the people that they serve, and then revealing to them, well, no, your thought about what's happening may not exactly be right. And I'll show you through some examples of how we change the minds of people that way. So in order to do that, we realized we couldn't just be a data-centric group. One of our 12 principles says if you didn't measure it, it didn't happen. So data is very important to us, but we also needed design. And a lot of these companies like Amazon, like Netflix, like Tesla, and all these companies that have created tremendous value and risen up really quickly as leaders in their industries, have also focused on design. If you've not read a McKinsey study recently, it shows the value of design and design as a focus. Almost 36% improvement in returns as if you compare a design-focused company to any other company within the same industry. So it's tremendous return on value. So we figured we need to have a design group, a development group, because we cannot always rely on someone else to solve our problems. We also need to have software developers that help us do that and create new solutions. And then surround all of that we make with good training and education. Because if you don't do that, then you implement a solution, you walk away, you go somewhere to do something else, and everyone reverts back to whatever they were doing before. Because either they don't have the information on how, or the continuous information that they need on how to use the systems you just created, or people move in and out of a system, right? There's attrition. And so new people that come in bring in new values with them. And if they don't use the systems you created, then you've just wasted a lot of time. So training and education is very important. And this is our very simple equation to leverage digital in healthcare. A lot of people ask us that. So what do we do that's different? And we always say to them, well, we don't do anything that's really different. What we do is we address these three areas. Improve access to our services, go to where people already are, so be convenient, and then finally close the loop. We're very bad in healthcare with that. We let patients leave even though they have something else they have to do, and we let them go figure it out on their own, and that's terrible. So you need to close the loop on digital experiences. And this was the equation I talked to you about earlier. You need to work with other people. You can't do this on your own. You need to work with your own patients also, not just vendors and partners and platforms. You also need to work with your own teams and the people that you serve. It's very important. And then a lot of in healthcare especially, we don't see our decline into obsolescence sometimes, right? A great example is with telehealth. So I was just talking to some people today about telehealth, and it's really odd that we call it telehealth even. John Scully, who used to be at Apple, once said that they used to call online banking telebanking, right, 10 or 15 years ago. And about 10% of transactions were done that way, from a consumer perspective. Now it's 90% of the transactions are done that way. 10% are done by you walking into a bank somewhere, right? So, and nobody calls it telebanking anymore. So that tells you the maturity of the industry to some extent. The fact that we still call telehealth means that we are somewhere around here on that maturity spectrum, and we got to get here, right? So we recognize that. We've invested in telehealth tremendously, even though it doesn't return as much revenue to us yet, but it will in the future. Kaiser's done a great job with that too. And so the challenges we face as an innovation team, as a disruption team, coming into an organization that's been used to people like us coming and telling them, oh, the world is changing, right? You need to change now. And then 10 years later, they're still in the same place, they still have the same jobs, and everything's going fine for them, right? They are very skeptical. Then you add to that, we are technologists, and they hate you even more, right? Because what has technology told medical professionals? That we're going to solve all your problems, we're going to come up with this cool thing called an EMR, and it's going to be fantastic. And then 20 years down the line, it's actually a nightmare for them, right? Terrible systems, horribly designed, and there's not much you can do about that experience because it is extremely expensive to create your own EMR, right? There are very few systems that still do that. And so how do you convince folks like this that a change you want to bring about in the organization is essential, it needs to happen now, and how do you tell a story behind that? And we found that data is really the best way to do that. And more so because clinical professionals are people that make decisions based on data, right? They don't just look at you as a patient and say, oh, I think you probably have the flu. Or, maybe you do have a fracture. They won't do that, right? They ask for tests. They will take all of that data. They'll be very careful about it, extremely conservative sometimes, and they'll tell you exactly what's happening to you. So internally, they have that mindset. They have that desire to kind of act only upon data, and they hate it when you tell them, oh, I think, okay? Wouldn't it be great if we made our front-end contact form or our appointment form smaller? Well, why? It's been working for us all this time. What do you mean it needs to be smaller? And we know it does, but we still have to give them a really good case with data behind it. And that's what we use platforms like Domo for. And before at Jefferson, we didn't really have rapid data visualization tools. We certainly had, data-based kind of tools that enabled us to collect legacy data and then present something, but nothing that did it in real time. And I'm talking about 4.5 years ago when we decided to go with Domo. And no quick and easy way to tell the data story, and nobody was really doing that. They would try to bring about change by collecting some legacy data, and it was always suspect. It wasn't real time. And I think real time is something that is very difficult for somebody to dispute, because after it's been validated, of course. Whereas they are very suspect of data that's been collated, presented in an engineered kind of way, because they don't know for sure whether that is right or not. But when they see it happening in front of them, and they are able to validate it within their practices even, they're much more open to change. I'll show you one example of that. So limited data-focused change agents, because people have just, I don't know why, but people have not done that, and maybe the technology has failed them, or it's too complex, or the data in healthcare is just too messy, and so people just don't want to engage in that, and it's very costly to clean it up and all of that. I worked in other industries, and even education actually is very, very data-centric, and they do collect really good data, and there are organizations that collect it for you too. So for me, this was kind of alien coming into a healthcare environment where people don't even know what the unit cost of something is. And that's really unfortunate, and we're talking about value-based care and all of that. If you don't know what an MRI, 10 minutes in an MRI or 1 hour in an MRI really costs you, how are you going to deliver that kind of care, right? How are you going to deliver to these new models that insurance companies and others are trying to build for you? You have to know that. And then ultimately, performance tracking even. Okay, if I've done something and I put something in place, how do I know it's really working, right? We don't do that very well. It's all hunch-based kind of analytics. And then finally, limited channels for making the case for process enhancement. And that's what we do through our design teams. I'll talk to you about that in a bit. So what's it been like? Domo has enabled rapid data visualization for us, has enabled a quick and easy way to tell the data story. Data-focused change agents are starting to come out of our organization now because they feel like they can tell this story and do it in an easy way, and it looks nice too, and it auto-updates, and reports get automatically sent out and all that, so they're happy about that. And then it serves as a channel for making the case for process enhancement. I'll show you examples of that right now. So this is one example, okay? This is our ER example, and I'll give you some background before I explain some of the metrics in here. And dashboards like this, in this case, we used Domo more as a prototyping platform than the final platform that we delivered the solution in, okay? That's a slightly different platform. So we were working with the ER, and the ER came to us saying, we think we need you to redesign the front end of our EMR system that we were using, because it's extremely confusing and people don't know what's happening at any point in time. We think that's what's contributing to a low level of, actually for a longer time in the ER that patients were spending. Also contributing to a high left without being seen rate. That means people that come to the ER, they get fed up of waiting, and they realize maybe I shouldn't be in the ER, and they leave, or even worse, if they actually did need to be in the ER, but they left. So we wanted to reduce all of that. And we felt, when we actually sent the design teams in to look at what the real problem was, the people that were looking at that EMR, they were like air traffic controllers. They knew that thing like, in the air. They could close their eyes probably and read it. So that wasn't the real problem. The real problem was that the people in the ER were waiting for direction from a charge nurse, for example. This happens in most ERs. It's very waterfall-esque, okay? It's not agile. People are not empowered to just make decisions and run into a room and try and solve a problem, right? So what we said to them is, how about we enable that? Enable small teams of people inside the ER to actually make decisions very rapidly. And so that's where we came up with this idea. And we said, what if we put up large screen displays, and they have large screen displays now across the ER, with non-PHI information. Okay, so we just refer to people as the room number, right? And then we showed certain types of information, like let's say readmission rates on this screen, and we made decisions about thresholds, which was an important exercise because it's pointless if you just showed up readmission rates, okay, how many people are coming in, and it was just a discouraging number for people in the ER. What can I do? But instead, if you said, okay, let's establish a goal, and if anything goes beyond that goal, we start contacting people. You, the ER folks, are empowered to contact cardiology or whoever and ask them, why are so many patients coming and readmitted, right? And so that was very different for them. And then what we did was, on top of that, we actually showed with a flag in real time when a patient came in, because now we are a larger health system, and with multiple different EMRs, we connected all those together for this particular platform. And we can tell a physician and the care team assigned to that patient immediately if that person is a readmit. And they get a text message through Tiger Connect, which is the text messaging platform we use, that immediately tells them this patient is a readmit. Okay, and so when they go into that room with that patient, and it shows up on there too on the screen with a little R at the bottom of that patient's of that room number. When they go into that room, they know that that person's a readmit, and they can speak to them in that way, rather than the patient telling them, "Oh, you don't know? I was at your hospital, a few days ago," which is interesting when a patient says that. All right. So what this did was it enabled, and you don't see it. And yes, correct. Those are the rooms over there. And you can see how many folks have gone over the threshold. So what happens is the physician or the clinician then is empowered just by looking up, right? You have a moment of latency. You think you can do something. Don't wait for the charge nurse. Look up on the screen. You don't have to access anything. You don't have to put your password in, none of that. Just look up at the screen and you see, patient in room 41 has been waiting for more than 15 minutes, right? Let me go and see what I can do. So before you go into the room, you probably speak to somebody, and then you try and solve the problem, right? And that led to a much more streamlined ER, where people were taking this onus on themselves to bring about change. We reduced, I'll show you the figures. So and Domo allowed us to prototype very quickly, so we could immediately just drop a thing in, as long as we had the data sources, we could drop a new display in the meeting. Not even, we'll come back to you later. We built it while we were sitting with them, and then we could question them and say, okay, what's the threshold? Sometimes they didn't think that we had to establish thresholds, but forcing them to think that way then enabled us to deliver something from the time they asked us. We did the analysis, and then we delivered, was about a month. The first few, it wasn't all of that, okay? It was just like 4 metrics. In an agile lean startup way, that's what you do. You say, okay, what's the 4 most important things? Not everything. And we'll deliver to that first. And then we validated those. And within the first 6 months, you can see there, we reduced the average time to physician by 23 minutes. We improved the Press-Ganey scores in 6 months, okay, to 84.5. Which from 82.2, which if you're in the healthcare space, you'll know is a big deal. Okay, it may seem like it's not. But our left without being seen rate, that was amazing. We dropped that from 4.6%, which is awful, to 1.2, and now it's stabilized at around about 0.8. And since we put in teletriage, it's gone down to 0.5. So we do teletriage in our ERs, and that speeds it up even more. And then reduce the average length of stay for discharged patients by about 42 minutes. So that's a lot of time saved, which is why patients were happy and were giving us those better Press-Ganey scores. So what we did speaks to the platform a little bit, because it was fast, it was easy, quick to do it, and people liked it, it looked nice, it was engaging. But it was more about telling that story to them, showing them the problem, right? So when you see this staring you in the face, you're doing something wrong, right? When you see, we created an algorithm, you don't see it in this one, that takes a lot of metrics and then tells you whether the ER is in saturation or not. Okay, and then when it goes into saturation, we actually send out text messages again to people in the administrative group of the ER, so that they know that the ER is in saturation. Many of them are physicians themselves, and they're ER physicians, so they might go in and alleviate that, or they might up staff in the flexible ERs that we have for staffing for the next shift. So we can do things that not only pull someone to the data, but also push the data out to them, and that's extremely valuable. It goes to where people already are, and it creates tremendous impact across systems like this. I'll give you another example. This was chemo insurance authorization, right? And the chair, he always tells us, if I didn't become a doc, I would have become a software developer. So it's a great guy to work with because he kind of spoke our language. But he felt that there was leakage. Patient leakage, for those of you that don't know, means patients that sometimes wait or for some other reasons, they decide to leave you and go to another health system, maybe, or another doc. So that's called patient leakage. And he felt like in his area, medical oncology, and they do a lot of infusion therapy and all of that, chemo infusion in this department, he felt that losing patients. It's hard to tell sometimes because the data is not staring you in the face. You're not looking at any data. It's just a feeling. He was seeing fewer patients. He wasn't seeing the same faces that he saw at the beginning of a week sometimes. Or a patient that came to him is suddenly not made the follow-up appointment. And so that's where he got this feeling. So he went to his staff and said, I think we're losing patients. And most of them said, oh, I don't think so, So then he said, well, how do I find out? So he contacted us because he used to fund a couple of software developers on our team. And he said, can you check? And we said, okay, first we need to find out. We need to send these folks into your space and see if this is really a problem. Talk to people. And it seemed like most of the folks were saying it's not our problem, it's the insurance companies. They're refusing authorization, right? And so that's causing a wait time. And we said, okay, let's try and find out what those wait times are. And then to find out what those wait times were, we had to find triggers inside the EMR, and we also had to build a solution that was a workflow management solution. So when somebody filled out the paperwork, and it passed on to someone else, because in healthcare, most of the labor happens in transitions. Okay, so somebody does something and they did their job, then they pass it on to someone else, and no one's measuring the amount of time in between, right? It's neither person's responsibility because they just don't know that this is in their queue sometimes. And so we measure that. And we found that on average, it was taking 22 days to get chemo insurance authorization in their department. And if you were diagnosed with cancer and chemo was your only option for a cure, would you like to wait 22 days? No, right? So that's why they were losing patients. And we went back to the staff and they still said, yes, it's the insurance companies. So then we had to slice that data and show them the insurance company and how long they would take. And the data we found was that the insurance company, the max time the insurance company was taking was 9 days out of the 22. So 13 days was them. Then we showed them, you see that little display there? I intentionally kept it small because it actually has the names of the physicians in it. Okay, so we showed them by physician who takes the longest amount of time and who takes the shortest amount of time to get the insurance authorization. So the chair didn't reprimand these folks. What he said was the person at the top should talk to the person at the bottom and find out what they do that's different, right? How did they get that through? And many times it was the quality of the administration, and the goals that they were setting for their teams, and so that helped to some extent. But then we went to the insurance companies and said, well, why are you taking 9 days? And they said, well, y'all don't submit good and complete documentation. So then we gave him all the physicians down there that don't submit, or who submits to doesn't submit complete documentation. Okay, who has the most bounce backs, basically. So then again, he had to intervene there. He had to let go of one person, the person right at the bottom there. And then the others because you can see that's a major outlier there. And then got the others to talk to each other, find out what they did different, set goals for them that by so-and-so date you have to change, right? And they couldn't deny this anymore because this was real data. This was each patient that was coming to them. So you can't say, and if they drilled down, they could actually see who that patient was or who those patients were because we were pulling that directly from the EMR. So they couldn't say, oh, this is suspect, or I don't think you're right, or this is anecdotal or anything. It was there for them to see, right? And so they had to change. And then you can see the numbers here. And I validated this even now. Some of those numbers are from 2016, 2017, right? So we went from 22 days to, on average, on some days, 5 days, and some months, 5 days, some even 3 days to chemo insurance authorization. And all these people weren't mean and evil people, that were coming in the morning and deciding we're going to make all these people wait to get their chemo. They just didn't know that they were contributing to a problem. And they just didn't know how to change or do something different. And some of them had figured it out, and some of them hadn't. And so the institution was suffering from this lack of knowledge sharing that needed to happen, right? And once that happened, not only did the institution see major improvements, but also the patients themselves, right? Because now you don't have to wait. And I validated this about a couple of months ago because now we're on Epic and we've created a solution inside of Epic that measures this continuously. And they told us it's down to 4 days now on average across, so from 5 to 4. So it's continuing and has a life of its own kind of, So that's very important, but they didn't believe it before. Right? And that cost was tremendous. So, and then we went on to do other things like chair usage, for infusion chairs, turnover of chairs so that people are not waiting for too long and all of that. Once you get into a group and you can tell a story like that, and you can show them how you can help them change, then they want you to do all sorts of other things. We even created an open table kind of application for them for all the infusion chairs. So not that the patient could pick the chair and you would in open table, but there was lots of noise around, okay, how long am I going to have to wait? I'm waiting inside this room. When am I going to get my chair? So we made that a lot easier with a data display that actually showed the patients in the waiting area when they would get their next, when they would get a chair. So it made it a lot less anxious. This was the thing I was trying to show you. 9 days, to request a schedule, and then how it dropped down. This was when we were. This was when we were going through from 2014 all the way to 2015, 2016. So this is a little bit of an older example, but very impactful nonetheless, and I use this still. And then after that, we started using, just because Domo's, and I have only about 2 minutes, Domo's, the neat thing about the platform, we kind of grew with the platform. We started 4 years ago on this platform. So for us, we've seen it evolve, and the evolution has been great in that new tools we're using, like ServiceNow is a tool that we use. Guess what? There's already a connector inside of Domo that takes the ServiceNow data and displays it. We use Google Analytics. We use Adobe Analytics for our web, and my teams manage that. There are connectors already for that. We use SAP's Jam software for our content collaboration platforms. We use Concur. Connectors already available for that. So, it makes you a hero kind of, in your organization when the travel group comes to you and says, hey, we need some better analytics. And we say, yeah, we can do that for you. How long will it take? About, 2 days. So they're really surprised when they hear that. Of course, we've checked in the back end whether Domo has this, has a connector already. So then we started using it for all sorts of things, for support calls and management of support calls in the organization. In Epic, we used it for our Epic transition, to present data displays to our transition team very rapidly, real time, all of that. We recently also moved to full HIPAA compliant Domo backend. So now we can post whatever patient data that we want in a responsible way, of course, but we are assured that it's well protected. So that's been great. So that's been our story with Domo. The real benefits that we found were the ability to bring about this data-driven change, performance tracking, engagement, do this type of thing, be a real change agent, in our technology kind of space, use information as a catalyst for change and technology as a driver for change, be human, and then ultimately some takeaways, because Domo wanted me to give you some very specific things, okay? These are, the designers how it works is one of our principles, and we felt that Domo really aligned with that nicely, because it's aesthetically very pleasing, but also easy to use. And it's very powerful, but unlike tools like SharePoint, let's say, right, which are very powerful, but they show you all those powerful features, right, in the main interface, and then the people that don't want to use them get so confused that, it hurts, and they don't use it. Domo is very powerful, but it hides all of those powerful features really well, and we like that. We feel that it wasn't just the platform, but also our ability to immerse ourselves in the environment and find the real problem before applying data and analytics to it. That was important. Very important to stay agile, I thought, and we agree within our teams. Create closed-loop solutions, as I mentioned earlier, and create this kind of ethos within our group that if you didn't measure it, it didn't happen. And you have to really take this seriously, okay? I mean, you can't just measure the product of what you do. And sometimes some people will push back on this, like Dr. Flommenberg didn't, and that was great. But some people don't like you measuring for a baseline, but you have to do it. So you have to measure before you do something good, because then you can prove to your board and other places that this really resulted in a change, and here's what the problem was before, and here it is now. And people don't like you measuring the problem before, but you have to do it. Otherwise, don't do the work sometimes. You have to show that change. And ultimately, meaningful, actionable data catalyzes change, and that's what we've seen at our organization. It's not like we've achieved what we wanted to achieve yet. Healthcare is a very, very complex space. There's lots of problems to solve. But we found that having a tool to tell the data story in a way that's convincing, real time, is very, very important, and that's what we've done. So, if there are any questions, I'll be glad to answer. Questions? Oh, in the back.
Yeah, so you mentioned integrating with your EMRs, particularly Epic.
Yeah.
I was just wondering, how was that getting data from those EMRs into Domo? Was that a arduous process?
Well, it wasn't an arduous process, but that was because we have the right kind of people on the team. So not a lot of health systems have software developers, and especially web service developers. What web service developers can do is they can go directly into the EMR, not even a EDW or an enterprise data warehouse or anything else, directly into the EMR, and through web services, APIs as well as traditional web services, pull this data in real time. And if you know how to do that, or if you can find the right kind of people to do that, it's very easy. And with Epic, you have to be a little bit careful, because Epic is very particular about who touches that kind of data. Right, and we are not pushing anything back into Epic. They're even more particular about that, right, for good reasons. So, but we don't find it too hard to do that, especially now that we understand the back-end systems really well, and they trust us. But it does take some time initially to develop that trust, and it takes the right kind of people who understand how to do this to bring that in. Yeah. But it's possible, definitely. Yeah. Yeah.
I'm super loud. Okay. I guess, did you encounter any physicians that were resistant to using the Domo data? And if so, how did you overcome that? Or did you find that they were all pretty open to?
No, it's not utopia still, because, and there are many ways that people try to deflect, they just won't respond sometimes, because you're revealing a problem, right? No one likes to be told that they are contributing to any kind of problem. And especially physicians, because, they didn't get into this profession to be a problem. They got into this profession because they wanted to help other people, right? So for them, it's really kind of, it hurts them when they hear that they're contributing to some kind of problem. So you have to also tell that story in a way that's empathetic, kind of, and not that's blaming somebody. Otherwise, you won't see them for sure. So we try to do that as much as we can, and better still, try to get them to believe that they are the ones who found that out, not us, right? So that's why the design team is really good. When you have a design team, they can go in and present and go through a discovery process with the folks rather than a pointing the finger kind of process. And then people change. But we make mistakes sometimes in that, and some folks, you don't see them again. It's not perfect. But most people do take it very positively, and they do change. Yeah. I hope I answered your question. Yeah, yeah, stay optimistic.
How did you go about gaining trust around those KPIs? And did you leverage the governance, or was there a process in place once you started seeing this thing evolve?
Yeah, so we don't. Well, one, we don't call them KPIs because then they get worried again.
Right.
Then also we don't bring governance or anything into it, because it's almost like as if you were a psychiatrist and that person was your client. You want to be as confidential as possible when you find the problems, because some people will trust us so much, especially now that we've brought about a lot of change. Like labor and delivery, for example. Recently, we went in there, and they had a discrete problem for us. But we always hate that when someone comes to you, worse still, with a solution, and they say, "This is what you need to make, an app or something like that." And we're like, "Well, what's the real problem?" And many times they can't tell us. And then, what's the real outcome you want to achieve? And many times they can't tell us. So if you don't know those two things, how do you know that thing's a solution? Right, so we try to discover that with them, and now they've understood our process. So sometimes they invite us in and say, "I don't know if you have any problems, but I'd like you to come in," because something that we've told them through our marketing is that, look, all of us, even us as a team, when we do work, we kind of are down there looking this way, right, at our teams. And so we see some problems, but if you were looking this way at, I don't see the person behind, I don't see the person. So you don't see some other problems, okay? And you never have the time to figure that out. Because why? Because you're doing your job day in, day out. So your camera is here and everything's happening here. We take your camera and we move it up here, okay, in a way that you don't have to spend time doing that. And then we show you all the problems that could possibly happen. So people now invite us in that way. They say, "Okay, we want you to shift that camera and tell us what's happening." And then we find, like with the ERs, we found 17 ways they could change different things that were contributing to latency. And they immediately implemented about 7. They didn't even need us for some of them. One of them was just taking a label printer that was here and putting it over there, or just buying another one. Why? Because people were taking a urine sample, keeping it on this table here, walking over to the label printer, printing the label out, coming back, and now there are 2 urine samples. So which one was it? Right? So now you got to go and tell the person to get you another urine sample, and that would be 15 to 20 minutes wait. So some were as simple as taking that and putting it there. Another problem was ultrasound machines. They were being used, and nobody was plugging them back into the Ethernet port because that was a tedious process. Right? And we saw that happening. When you take that other view, you see suddenly an ultrasound machine sitting here, another ultrasound machine sitting there, and you're wondering, okay, well, how's that being used? Why isn't it being connected in? And because it wasn't being connected in, no charges were being put in for any ultrasound that was being done in the ER. And we quantified that number. It was from each machine, almost $1.25 million in charges were not being charged anywhere, right? Why? Because someone didn't want to plug that in. And then we found out that the same machine actually is Wi-Fi enabled. And we put in a request to IT, and they took a long time to put in a really high bandwidth access point. And now they have 5 ultrasound machines in the ER. So when you find these weird things. There's no Domo, there's no data, there's nothing of that sort, but it's just go in and observe, and then you find these weird.
When you disperse this information, you did it on just the big screens, or those were apps on their phones and stuff?
Oh, no. We didn't do apps on the phones, but they could certainly, because Domo is available as an app, right, to them. We always measure friction in anything that we do. Right? Doing an app meant taking the phone out, opening the thing, then flipping through I don't know how many displays, right? Whereas if I just looked up and the screen was there, done, zero friction, right? So that's why we did that. But there were some administrators that we gave apps to, because one day we were in a training session and one of the ER administrators was there with 2 laptops. Why? Because he liked this dashboard so much that one laptop was just open to the dashboard and the other one he was doing his training, right? And he kept on looking to make sure that the ER wasn't in. That's when we also realized we should text them, so that they're not doing this all the time. so for him, we gave him, the Domo. We showed him how to use the Domo app and all of that, and then we did the texting thing afterwards. Yeah. Mm-hmm. Cool.
So the
Yeah.
use case, and then you've got your IT use case as well.
Yeah.
The call centers and so on.
Yeah.
You also using it across the business? So
Yeah.
financials.
Yes. Well, not so much on the financial side, because they have very specialized software for that. But I see, and also because we had a limited license of Domo, that's why we deployed it in discrete departments first. Now we have an enterprise-wide license. So, because if you do a finance thing and they say, no, this needs to be dispersed to the board and all these folks, suddenly I need all those licenses, So we didn't do that in that way. We had that constraint, but now we have an enterprise-wide license. So yes, that's going to start now. Yeah. 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 Yes. Yeah. Correct. Yeah. So you can bring about a lot. We had to find out ways to kind of create the greatest impact with what we had also. So. Yeah, cool. All right, any other questions? I think I'm a little bit over my time, so. All right, great. Thank you very much. Thank you for taking the time.